good afternoon, everyone. A warm welcome to you all on a sunny day here in Chicago and taking the time to join us. And I'd like to give a special shout out of gratitude to our University Senate who is sponsoring this webinar with us. I'm Elaine Morato, professor and founding dean of the Parkinson School of Health Sciences and Public Health. And I'm very pleased to be the moderator for today's discussion on vaccines and the Loyola community. You know, the pandemic has certainly put our trust to the test. And I was reminded recently that over the past year, employers have emerged as a mainstay of trusted information. And we have received many positive comments to Loyola's Return to Campus informational webinar series. And so today really is a continuation of that tradition by sharing what we know and responding to your questions today about the COVID-19 vaccines. We know that we won't be able to answer all questions in an hour, but we will do our very best in answering what we can, as well as directing you to trusted sources of information that you can follow on your own to stay current to this continuously evolving situation. As some of you may know, I joined Loyola a year ago, last February, and I enjoyed a month working on campus. And then like many of you, we've been largely working from home. As an epidemiologist and as an academic public health professional, this truly has been a remarkable time. But I've been very comforted by the scientific and operational expertise at Loyola that has been working very hard to steer us all through these uncharted waters. And this afternoon, we'll be bringing some of that expertise to us in our webinar and dialogue. You'll be hearing from faculty in the Parkinson School who have expertise in epidemiology, from the Stritch School who have expertise in infectious disease and immunology. And in addition, you'll be hearing from university administrative staff who, along with faculty from our health sciences school, have been working together to synthesize the rapidly changing public health landscape and information and helping us to inform Loyola's own logistics planning and health safety initiatives. And I want to reassure you that Loyola has really truly taken a multidisciplinary COVID-19 team approach to stay on top of evolving federal, state, and local public health guidance, to be tracking key indicators in the Chicago area, and to be modeling learning and adapting best practices from other universities to keep us all here at Loyola University Chicago, our community, safe. So this afternoon's webinar is one in a series, as I've mentioned, that has hosted for various community members and audiences. That includes students, parents, faculty, and staff. The content today is largely focused on questions that we've received from faculty and staff, but we know that we have a diverse audience here, and we hope that the information can be helpful for you all. We will be specifically discussing three topics: the science behind COVID-19 vaccines, vaccine distribution and eligibility, with a particular focus on here in the Chicagoland area, and how the vaccines will fit into our ongoing Loyola campus surveillance testing and risk mitigation. Today, I'm pleased to be joined and welcome the following panelists, some of whom are leaders within the university's Management Policy and Command Group, the MPC. This is the group that's charged with university's overall management and emergency preparedness during the pandemic. So our panelists will include Dr. Nina Clark, professor and director in the Division of Infectious Diseases at the Stritch School of Medicine; Phil Hale, who's vice president for civic engagement and a leader on the MPC Planning and Intelligence Working Group; Kana Henning, who's associate vice president for facilities and also a leader in the MPC Operations and Campus Continuity Working Group; Dr. Joan Holden, who's director of the Loyola Wellness Center, as well as the university's health safety officer and leader of the MPC Healthcare Advisory Working Group; Tom Kelly, who's senior vice president and administrative services and leader of the MPC; Dr. Abigail Silva, assistant professor in public health sciences at Parkinson School of Health Sciences and Public Health. And lastly, Dr. Susan U. Pritchard, who is Professor of Medicine and Microbiology and Immunology at Stritch School of Medicine, who along with Dr. Nina Clark, directs Loyola's Infectious Disease and Immunology Research Institute. She's also our chairperson of University Senate. So before I turn it over to our panelists who will be walking us through various information for us, I want to just review some housekeeping notes for everyone. As was mentioned, we will have time for Q&A after each speaker discusses a topic. We will be answering questions that have already been sent in and have been suggested when you registered. And we also encourage you to submit questions in real time, as was mentioned, via the question and answer function. And we have several experts behind the scene, including faculty and staff from schools and departments of all 3 Chicago campuses who will be responding to the Q&A. And that includes representatives from Residence Life, the Office of the Provost, Student Development, as well as the Wellness Center. We anticipate that we'll be concluding around 5:30, but our Q&A experts will remain online to make sure we provide written replies to any remaining questions at that time. We really do encourage questions. I know from the last webinar I participated in, we received several hundred, and the Q&A behind the scenes crew answered them all. And so this is important that your questions are answered. The event is also being recorded and will be posted to the Return to Campus website on Monday, on March 8th. Really, our goal here today is to continue the conversation and provide you information around vaccines to make sure we're answering your questions and you have the knowledge you need to keep yourself, Loyola, and our surrounding community and families and friends safe. In fact, your safety and that of the entire Loyola community is really what's most paramount to us today. So without further ado, let me introduce our first panelist who will be talking about COVID vaccines 101. It's my pleasure to introduce Dr. Nina Clark, Professor and Director of the Division of Infectious Diseases at Stritch School of Medicine, Dr. Susan U. Pritchard, Professor of Medicine and Microbiology Immunology, also at Stritch, and Dr. Abigail Silva, Assistant Professor in Public Health Sciences at the Parkinson School of Health Sciences and Public Health. Thank you.
Thank you, Elaine. I was asked to provide some information about background on the vaccines. So I thought I would start with the emergency use authorization designation that these vaccines have. So the EUA designation allows for rapid and widespread distribution of medical products when there's scientific evidence available to support the use of that product, the known or potential benefits outweigh the known and potential risks, and there are no available adequate alternatives when there's a life-threatening disease or situation such as we have with the current pandemic. What's important to note is that the level of scrutiny for EUA products is similar to fully licensed products, and that the FDA continues to collect data on EUA products and do an additional review prior to granting full licensure. This slide shows some of the vaccines that you may have heard about and our current types of vaccines that have EUA designation. So on the bottom, there is the mRNA vaccine. So this product has the genetic information that allows the body to make a certain protein of the virus called the spike protein. So when the mRNA vaccine is injected, it's taken up by macrophages that produce the protein. The body senses that as foreign and develops an immune response. The second type of vaccine that we have is an adenoviral vector vaccine, where the DNA that encodes the spike protein is inserted into an adenovirus. And these adenoviruses that are used have been altered so that they're not infectious and they can't replicate in the body. And adenoviruses are common cold viruses. So when that's injected, the viral particles enter the body can produce the spike protein and then an immune response. Protein-based vaccines are in development but aren't currently available, and that involves just making the spike protein and purifying it in the lab, and then using that as the vaccine, injecting that into the body. So this slide shows some of the information that's relevant on the currently available SARS-CoV-2 vaccines that have EUA designation in the US. The first row is relevant to the Pfizer vaccine. The second has information about the Moderna vaccine. Both of these are the mRNA vaccines. And then the third row contains information about the adenovirus vector vaccine. You can see in the third column the differences in dosing. So the big advantage of the Janssen or Johnson & Johnson vaccine is that it's a single dose compared to the mRNA vaccines, which are 2 doses. Only the Pfizer vaccine is approved for use in older age adolescents, year 16 and above. The other 2 are for ages 18 and above. And what's really exciting and important is how effective all of these vaccines are. So the efficacy in the US is indicated in this column. The mRNA vaccines that many of you have heard about are almost 95% efficacious. The adenovirus vector vaccine in the US is 72% effective. And then all 3 are very effective against severe disease, which we classify as someone having pneumonia and their oxygen being low, perhaps needing hospitalization, ICU stay, and worse. And what's most important is that there have been, in this last column, no deaths related to COVID among any of the vaccines in these clinical trials. So in summary, all of these 3 vaccines are very effective, particularly at preventing severe disease and hospitalization and death. There has been a lot of publicity about the efficacy of the Janssen vaccine. And what's important to know is that it was not directly studied head-to-head with the mRNA vaccines in the same populations at the same time in the pandemic. And they were enrolling patients at a time when there were more viral variants prevalent, which Dr. Upritcher will talk about. But all of these are very effective, and the message is that you should be vaccinated with whatever vaccine's available to you as soon as you can receive it, and not to wait. And currently, the supply that the vaccination distribution site receives determines what vaccine you receive. Unfortunately, we don't have the luxury of choosing which vaccine we'll be receiving. As far as safety, these were very large clinical trials and all enrolled tens of thousands of patients, and we have vaccine safety data on those patients. We also have this vaccine adverse events reporting system that was instituted in the US in 1990 to provide early warning signals about potential problems with vaccines. And this is a system that's being used to monitor potential adverse events with COVID vaccines. So what's very common with these vaccines are some level of side effects, predominantly local side effects like injection site pain, but also some systemic side effects like headache, fatigue, muscle aches, chills. Most of these are mild to moderate in severity, so they generally don't require days off of work or medical treatment, but in some cases they might. But they do resolve in a short period of time, usually within a couple of days. We do have a recent publication about a 1-month follow-up of over 13 million doses of the mRNA vaccines, and it's very reassuring that there was a relatively low rate of adverse events reported, so a little over 6,900, and a minority of these were serious reactions with 113 deaths, but those were mostly in elderly persons who were in long-term care facilities, and they were all deemed to not be related to the COVID vaccinations. You may also have heard about the problems with allergy, and unfortunately that has turned out to be very rare, so approximately 4.5 cases per million people vaccinated. And that is on a rate that's similar to other non-COVID vaccines, and much less, for example, than we see with administration of penicillin. Importantly, there haven't been any unexpected reactions reported thus far. There is some accumulating data about using these vaccines in pregnant women, and there are registries tracking this. There are over 30,000 pregnant women who have received mRNA vaccines that have been registered in VAERS or the vSafe mobile application. And we do need additional follow-up on this, but fortunately there have been no serious safety signals thus far. There are also animal data on these vaccines that haven't shown any adverse effects on fetal development. The American College of Obstetrics and Gynecology does recommend that pregnant or lactating women not be denied the vaccine if they would like to get the vaccine, and many women have chosen to do so. And we do know that pregnancy increases the risk for severe COVID-19 and death, as well as preterm labor. So I think this is a very reasonable thing to elect if you're a pregnant woman. Finally, I'll just touch on vaccine hesitancy. So there is, of course, longstanding suspicion about vaccines in general, and a lot of this has been fueled by misinformation, such as prior publications that have since been retracted on a link between autism and MMR vaccine, for example. So we know as providers and scientists that sometimes providing fact-based information isn't enough for people to want to get a vaccine. There are many diverse reasons for hesitancy, and there is no one size-fits-all approach to addressing this. So I think we need to listen to people's concerns, be non-judgmental, non-confrontational. I think in some cases, citing one's own decision to get a vaccine or one's family members may be influencing people to feel more comfortable with taking the vaccine. And I think one message is that getting vaccinated not only protects the vaccinee, but protects others, including perhaps vulnerable people who may not develop an adequate immune response to vaccines. We need to be honest about side effects, not de-emphasize those, but relay that these are manageable, and emphasize that we do have a safety system in place to monitor side effects. And then finally, having trusted messengers are important, whether those are community leaders or religious leaders or even media personalities. And the CDC is trying multiple approaches to help encourage people to get vaccinated. So with that, I'll turn it over to Dr. Pritchard, who's going to discuss viral variants.
Okay, so I will be discussing the topic of variants. As I'm sure many are now aware, viruses mutate and evolve as they replicate. As of late January, there were over 350,000 SARS-CoV-2 genome sequences logged into the Open Access Global Science Initiative. And within those sequences, there was over 20,000 mutations documented. So the viral population is quite dynamic, and that's shown here where you can see the virus changes over time, color-coded based on the relatedness of the sequences. Now, scientists follow this every day, sequencing as many of the nasal swab and saliva samples that they can, but the public doesn't hear about all these mutations because for the most part, these are random mutations, and so many of them don't provide an advantage to the virus. And so they're not considered to be of concern. But looking at the next slide, there certainly are variants that are considered of concern. And that's when they are spreading and becoming more prevalent in the sequencing that's being done every day. When they have mutations in the viral spike protein, particularly the receptor binding domain, which is where the virus actually binds to the host cell receptor to enter the cell. And when mutations are seen arising multiple times independently, as that suggests that those mutations might provide an advantage to the virus. So the top 3 variants of concern at the moment, which are listed here, all have those 3 properties. They're all increasing in prevalence. They have multiple mutations in the spike protein, including the receptor binding domain, and I've put those in bold in the 3rd column here. And they have several of the same mutations, which have arisen independently. So then how concerned should we be about these variants? The UK variant has been shown to be 40 to 50% more transmissible. And in fact, it's predicted to become dominant in the United States. But both Pfizer and Moderna have shown that the antibodies generated by their vaccines block the entry of this variant spike protein. The South African variant also appears to be more transmissible. At the moment, there's only 32 cases in the United States, so not quite as prevalent, certainly not as prevalent as the UK variant. And both Moderna and Pfizer have published about these variants as well. So Moderna has tested a variant with all 5 of these spike mutations. And while there was a 6-fold reduction in the neutralization by the vaccine-induced antibodies, it was still well above the level that would be considered protective. So when people do these assays, they titrate down these antibodies to a very low level to figure out how sensitive and protective they are. Pfizer has also tested a construct with one of the key receptor binding domain mutants and found no reduction in neutralization. So we have reasonable data for the first 2. The Brazil variant will have to wait for the data. It does have many of the same receptor binding domain mutants as the South African variant. However, it also has quite a few more mutations in the spike gene, and so it will have to be tested independently. Now, all that being said, I want to end looking at the big picture. So these vaccines induce antibodies that bind to many epitopes or many places on the spike protein. And so when mutations appear, it doesn't necessarily mean you're going to get escape from all of those antibodies. You're going to have portions that are no longer useful, but other antibodies that still exist. And so it's these antibodies, these pool of antibodies together that contribute to that protection. And so we should definitely monitor these variants very closely and test them one by one to determine their level of escape. But currently the vaccines are continuing to provide protection. And I think a really important point is at the moment, the vast majority of the virus that we know of in the United States is neutralized by these vaccine antibodies. And importantly, vaccination as well as mitigation practices greatly reduce the spread of the virus, both wild type and mutant. And this is important because when you reduce spread, you reduce the replication space of the virus. And if a virus isn't replicating, it's not generating more mutants. And so this is really our key to staying ahead of these variants, is to continue our mitigation practices and get vaccinated as soon as possible. And then to end just on a positive note, one of the advantages of the mRNA vaccines is the ability to generate booster vaccines very quickly. And so the companies have already started to design those. And so getting vaccinated and getting that first series will help put you in a position to get those booster vaccines very quickly.
Oops. Of course I did that. Sorry about that. Sorry for that delay. I had it all set up, and of course it had to happen. So let me tell you a little bit about herd immunity and the role it's playing in the current pandemic. First, what is herd immunity? Herd immunity refers to the resistance of a group of people to an attack by a disease to which a large proportion of the members of the group are immune. Herd immunity relies on the idea that if enough people in a community are immune to the disease, then they help interrupt the transmission of that disease to other susceptible non-immunized people. So this is a really nice graphic that shows you how herd immunity works. The purple folks represent non-immunized but healthy people, susceptible population. The yellow are immunized and healthy, whereas the red are not immunized and sick or contagious, if you will. In the top population, you see that among the 50 people, no one is immunized, and there are 2 sick and non-immunized folks. What happens over time is that the disease spreads, and now 45 of the 50 people are sick. In the middle population, you see that among 50 people, we will have 2 sick, non-immunized folks, but we also have 6 healthy immunized folks. So what happens over time is that the disease still spreads, but now only 39 as opposed to 45 get sick. The immunized folks helped provide some level of indirect protection to the susceptible folks. In the lower population, among the 50 people, we still have those 2 sick, non-immunized folks, but we also have 44 healthy immunized folks. What happens over time is that the disease spreads to 1 person while protecting 3 susceptible people. This last example shows achievement of herd immunity. And experts are estimating that herd immunity would be required around 80 to 90% of the population in order for us to achieve herd immunity for COVID-19. So, however, the path to get there is long. This graphic illustrates how we can achieve herd immunity through a combination of immunity that is achieved through infection or through vaccination. So currently, as you could see, most of the immunity in the population has been a result of past infections in the population. But we are now increasing immunity levels through vaccination. As vaccination levels increase, we have less cases in the population, and herd immunity then becomes more of a function of the vaccination. Now, there are potential roadblocks toward herd immunity. Vaccine distribution is no simple matter. There are over 200 million adults spread across 50 states with close to 3,000 local health departments. In addition, a couple of the current vaccines need to be kept at specific temperatures and require 2 doses. And just because President Biden tells us that in May we will have enough doses for all adults, he's not saying that they will be in our arms by then. We need to find and set up places and find people to deliver those vaccines into our arms. And we need to do it in a way that's accessible to the community with special attention to the most vulnerable populations in our community. Vaccine hesitancy, as you heard, is a real issue. And vaccine hesitancy in the population can also pose a barrier to achieving herd immunity if a sizable portion of the population opts out of receiving the vaccine. And of course, there's also the risk of new variants being more resistant to the current vaccines. That's possible, but not, of course, if we get immunization out there as fast as possible. Regardless, it's a race against time in many ways. So this slide is just meant to remind us that it is important not to let our guard down. If you look closely at this graph, you see that the current levels of cases and deaths due to COVID are really the same as they were in the summer when we were on a more restrictive lockdown, right, than we are now. Furthermore, Americans have lost a whole year of life in terms of life expectancy. And that usually takes more than a decade to gain an increase in life expectancy. Furthermore, as you can see, Black and Latinx Americans lost substantially more years of life lost as a consequence of this pandemic. However, I also want to end on a hopeful note. We still have tools in epidemiology, right, or in public health to stay safe, right? We know that washing our hands, covering our faces, and keeping our distances has been working, right, and it's effective towards keeping transmission at bay. And of course, we also have the box it in strategy, right, where we test folks, we identify those who have the infection, those are isolated or receive treatment as needed. We identify who they might have exposed. We contact those folks, right, and have them quarantine and so on. So we do have many public health tools to keep us at bay as we ramp up all this vaccine distribution.
Thank you very much, Abigail. Susan and Nina. That was really great. We're very fortunate here at Loyola that we have the expertise that we do at our health science campus. And thank you for taking us and giving us the 101 version of that. I know some of the questions that we have here, we're going to be talking about, a lot of them are more directed clinically. And so we'll be asking Nina for some follow-up. Continue asking your questions. I know there are ones that relate to availability and access. That will be covered in our next section. So we are noting, and I just want you to know we'll get to that in the next one. So my first question for you, Nina, is, how should we interpret the vaccine efficacy? You went through some nice tables, but folks are still having questions when, how do you compare 95% efficacy or 66%, or how should we think of it when we say, is it effective or not?
Right. So a 100% efficacy would mean that there are no infections that occur in vaccinated patients compared to whatever rate there is in the control or placebo population. A 0% efficacy would mean the vaccine wasn't at all effective and the rates of infection were the same in the vaccinated people compared to placebo. And so you're comparing rates of infection between the two groups. And 95% efficacy would be, almost 100% reduction in the rate of infection in a vaccinated group. And the FDA had provided guidance to companies when they were developing these vaccines that they would consider effective any vaccine that was 50% efficacious or reduced the rate of infections by 50%. And that's kind of on the order of our flu vaccines every year. 40%, 50% would be good. So these are very effective vaccines.
And highly, highly effective when we think about preventing very serious disease, hospitalization, and death, and really notable there. So our second question is, recognizing that they're dosed in different ways, and some of them, the Moderna and Pfizer, require 2 doses. What do people do if they've missed one? Do they have to start all over again?
No, there's no recommendation to restart the series. And in fact, our supply is so limited, we can't really do that anyway. But the CDC has said that vaccinating someone out to 6 weeks after their first dose of an mRNA vaccine is thought to be efficacious. Beyond that, we really don't have data. So, try any way possible to get the second dose on time, perhaps out to 6 weeks, but beyond that, we're not sure what the effectiveness is. And that's a huge advantage for the Janssen vaccine, that it's just 1 dose and we don't need to worry about a second dose, at least at this point.
Right, exactly. So you talked about safety for women who might be pregnant, pregnancy. What about nursing mothers? Safety for the nursing mom as well as the baby. Is there any data on that we can refer to?
Unfortunately, we don't have significant data to speak of. It is recommended that nursing mothers still consider getting the vaccine because of the benefits and because we've seen really no safety concerns with other non-live, non-replicating vaccines in the past. So the current coronavirus vaccines don't replicate in the body. They can't really be transmitted to the baby, so it's thought to be safe, but we do need more data.
Yeah. All right. So I get vaccinated. What does that mean in terms of whether or not my odds of transmitting the virus? So if I'm vaccinated, do I still need to wear masks, wash hands, or am I free?
You still need to wash hands frequently, wear masks, social distance, follow the guidance from your employer, from the CDC. So, these data are emerging too. It seems that there is protection against asymptomatic infection when you're vaccinated, but probably not 100%. We do have some data from the Janssen trial, a limited subset of patients were followed for asymptomatic infection, and the vaccinees appeared to be protected about 70% or so. And then there's real world data from Israel that was just published, and there they've made a lot of progress with vaccinating their population, and they're seeing less asymptomatic infection. The other data are that when vaccinees get infection, it seems like their virus levels are lower, so less likely to transmit. All that being said, there still can be infection despite vaccination. There may be people who don't respond to the vaccine appropriately, so we still need to follow all the current guidelines for masking and social distancing.
So when in doubt right now, while that data is being collected, let's be precautious and continue, as you say, with what we know works highly in terms of masks and such. One last question. If I hear what Susan and Abigail talked, we're in an arms race right now, right? Between the human versus the virus, achieving immunity through vaccination versus outrunning the mutations that are occurring right now. And I heard that we might need to get to 85, 90% of the population. And that does include children if we're to get to that number. So a question that many are asking is, when do you anticipate that the vaccine might be available for school-age children?
Yeah, that's a great question. I don't know for certain, but those trials are being undertaken now. And, I've heard Dr. Fauci say that he expects those data to be available by the end of this year, and hopefully the vaccines will be effective in that population, and there will be approval and ideally vaccinations by early next year.
Yeah. I think it is also good news that the government has been thinking about manufacturing and availability in anticipation of having vaccine for children. I think the recent news also around Merck partnering with Johnson & Johnson in terms of manufacturing to increase supply. It's all good news in terms of anticipation of having enough vaccine available for all. So that is the last question that we had that is in our efficacy and safety and what do variants mean and what does herd immunity mean 101. I know some are still asking this question around, gee, I still might be hesitant. And I just wanted to include with a quote I looked up that comes from Pope Francis and his advisory on COVID-19 and his commission, who just reminded us how important it is that we work together and that individuals have a moral responsibility to get vaccinated if they can, because refusing it constitutes risk for other. I think no time like now is our collective action around this really important, not just protecting us individually, but our community and those that are most vulnerable. So I want to thank our scientific experts around the disease and epidemiology. And we're going to turn now to what does this mean for us and when availability, because I know many questions have been coming in on that. So let me now introduce our next set of panelist speakers who will be talking about this. So Tom Kelly, as I mentioned, who's our MPC leader, and Phil Hale, who is our Vice President of Civic Engagement, as well as leader of the MPC's Planning and Intelligence Working Group. And they're going to talk to us now about what does this mean for us locally and how might we get vaccinated. So I'll turn it over to you, Phil.
Great, thank you very much, Elaine. I'm going to focus on a couple of areas. First, who does qualify for a vaccine and when. Also, how to go about getting a vaccination, and a little bit about our own advocacy around vaccinations for people working in higher education. As I go along, I'll do my best to highlight some websites. A lot of these should be popping up in the chat, so please look for that. They were also on the slides at the beginning of the webinar, and those slides will reoccur at the end of the webinar. Also, all of these key websites and, in fact, the recording of this whole webinar will be available on Loyola's own designated vaccine web pages, which will be available very soon. So first, who does qualify for a vaccine? I wish there were a simple answer to this. Unfortunately, it differs a lot depending upon where you live. Well, I should say a lot within the overall CDC guidance, but it does differ from state to state, and in some cases, even from municipality to municipality. I'm going to focus principally on the city of Chicago. I'm primarily going to review the city's guidance, but Cook County and Illinois are very similar to Chicago's vaccination plan. And again, all of them are patterned after the CDC guidance. Again, on our web page, we're going to have links to the CDC website, several vaccine finder pages, as well as links to the Chicago and Illinois Departments of Public Health. So here's a quick overview of the vaccination plan for the city of Chicago. As you can see from the slide, this is broken up into phases. Phase 1A includes healthcare workers, long-term care residents and staff. These are all currently eligible and have been since December 15th. Group 1B includes frontline essential workers, first responders. This also includes grocery store workers, daycare workers. It does include people at K through 12, as many of you already know. Does not include higher education, and I'll talk more about that later. And it includes people who are age 65 and older. Everyone in this phase is also currently eligible. It also includes people, Group 1C includes other essential workers, plus people who are age 16 to 65 with an underlying condition. This will include in Chicago, Cook County, and Illinois, higher education staff and faculty, people working at colleges and universities. It also includes a lot of other people. So for example, phase 1C includes people working in transportation, bus drivers, people working on the L, people working in food service, construction services, your plumber, who will need to come and help you out of isolation, IT, communications. It even includes lawyers. So a lot of people are going to be in phase 1C. Group 2 or phase 2 includes essentially everybody else who wasn't in one of these designated phases above the age of 16. As Nina mentioned, at this time, none of the vaccines are authorized for anyone below the age of 16. It's also important to note in the city of Chicago that this plan includes people who work in the city, as well as people who are residents of the city of Chicago. Healthcare workers, for example, who live in the suburbs, but who work at one of the Chicago hospitals, have been able to get a vaccine in Chicago as well as in their hometown. And similarly, for Loyola faculty and staff who do not live in the city of Chicago, but who work on the Water Tower campus or the Lakeshore campus, you'll also able to be vaccinated in Chicago as well as in your hometown. So timing is very much geared to supply. And as many have noted, supply is currently very limited. It also will depend on the distribution plan for wherever you're living, your state, your municipality. In Chicago and Illinois, if you qualified for a vaccine in phases 1A or 1B, again, you're currently eligible. We strongly encourage you to get a vaccination if you haven't already. For higher ed, phase 1C is projected to be eligible in the end of this month, March 29th. After they rolled out their vaccination plan, Chicago did add some tiers within phase 1B. So for example, people under the age of 65 with underlying conditions have only just recently been eligible in phase 1B tier 2. The Illinois Department of Public Health estimates that in phase 1C, there will be about 4 million people who are going to qualify. Again, essential workers and people with underlying conditions. So we're also anticipating that phase 1C will be phased in. We'll have sub-tiers within the phase. Unfortunately, at this point in time, we don't know what those sort of sub-tiers are going to look like, but we're monitoring that very closely. By May 31st, Chicago projects that they'll be in phase 2 and that everybody will be able to get a vaccine. And this is where most of our college students will be able to get vaccinated, or when rather, if they haven't already qualified through some other means. So by the time that most of us are eligible on March 29th, supplies will still be limited, but we still encourage everyone to sign up as soon as possible, even though vaccine providers are not going to have enough supply right away for everybody. There is good news, as a couple of people have mentioned. Just this Tuesday, President Biden did announce that he expects that in the United States, they will be taking delivery of enough vaccine for everyone above the age of 16 to be vaccinated by May 31st. This is 2 months earlier than his original forecast. This is not shots in arms. This is vaccine supply, but it's still excellent news. And it means that by the end of May, vaccine supply and distribution should be keeping up with demand. This is very good news for everyone at Loyola, because it means that by the time the fall semester starts, faculty and staff should have been able to get a vaccination. And many, in fact, maybe even most of our students will have been vaccinated by the time the fall semester starts as well. So how do you get a vaccination? Again, this will depend largely upon where you live, but the process is roughly going to be the same. Start with your city or state public health departments. For people living or working in Chicago, I strongly recommend the official website, zocdoc.com/vaccine. Happily, this is, I think, in the chat and on the slides. This is the official link to register for a vaccine in Chicago. It's also being used by many other states. So if you don't live in Illinois, please still check it out, because you might be able to register where you live, even if you're not in Chicago. If you do live in Chicago, though, please do check out COVID Coach. This is an app that's operated by CDPH, and it's where all of the details for the city of Chicago's testing plans, vaccination registration is being posted, and how you can get notified about exactly where you'll be able to register. Again, if you don't live in Chicago, please check out zocdoc.com, as well as your own local and state health department. And please consult these sites frequently, because this information is constantly being updated. We're in a period of significant and rapid change, both in the science, but also in the manufacturing and distribution. So please check these sites on a very regular basis. In addition to the ones I mentioned, I would also strongly recommend a few other sites. Vaccine Finder, the official CDC site is excellent. And NPR, National Public Radio, has a wonderful site as well to help you find, wherever you live, where and when you're eligible to get a vaccine. You just enter information according to a series of questions to see if you qualify. Most states and municipalities also control everything about their own vaccine distribution through every individual provider. In Chicago, CDPH controls every single vial of vaccine. And this is true whether it's distributed through the United Center or any of the other mass vaccination sites coming online, a hospital, a pharmacy. CDPH is controlling every vial. So wherever you do go to get vaccinated, please understand that your provider is not going to have any control over their supply. Each week, they're going to provide the governing department an estimate how many vials they think they may need. Obviously, well, they also won't have any control over which vaccine they can offer, though if they'll have to have a special freezer for the Pfizer vaccine. But again, your provider won't have any control over when or which vaccine they will be able to provide you. So please be patient with them. I'm going to turn now to our advocacy very quickly. Since last spring, I've been serving on both the Chicago and the state of Illinois working groups for developing industry-specific guidance for higher ed. The city's group meets with the mayor's office and CDPH once a month. Through these groups and through a lot of other means, Loyola has been lobbying. We actually lobbied to get higher ed included in phase 1B, arguing that our faculty, our staff are working directly with students just as K through 12 teachers are. Clearly, we weren't successful in that, nor getting higher ed in general included in 1B, but we have had some successes. Anyone, for example, who's working at our wellness center or one of our on-campus testing sites qualifies as an essential worker in phase 1A. Loyola and our colleagues were also able to get groups of workers included in some of the essential worker groups in phase 1B. These include people working in our residence halls, people helping to supply our grab and go food for our students living in the residence halls as well. And there have been a couple of other groups that we've been able to help. Sorry to have rushed through this, but I know we have a lot more information to get to. So I'm going to go ahead and transition now to Tom Kelly. I hope this overview has been helpful, but I'm going to turn it over to Tom now, who will walk us through how Loyola is going to be helping people get vaccinated. So Tom, thank you.
Thanks, Phil. I'll try to quickly move through a couple of those questions so we have time to that we got in advance. And I know that if we have time, there's a lot of questions coming in through the chat. As you've heard before, we need to level set some expectations about what Loyola can do right now and what it can do in the future to help with vaccine distributions. Right now, and you've heard this early and often, no provider, no employer has been able to speed up their access or get more supply. It's all being distributed out by the states or the counties or the municipalities based on the priorities and tiers and their interpretations of those. We are very optimistic, as you've heard, that there will be plenty of supply come May, and then we need to continue to work on the distribution of that. We also need to start working now on vaccine hesitancy, on providing information, providing encouragement, responding, and encouraging others to take up the vaccine, both in our campus communities and the communities and in our families. And we hope to do that. Getting the vaccine is the biggest and brightest light we've had in this very dark COVID tunnel. And so let's all take it up as soon as we're able. The other thing we're doing as we're able to identify people in the tiers, we are doing everything we can to communicate that they should take the vaccine up, especially now, wherever and whenever they can. It's not going to be able to be provided by the university at this time, so they need to seek that out for themselves. We're going to provide tools, we're going to provide education, we're going to do things like we're doing right here to help inform the community, and then we'll be able to do more when there is more. One of the questions we got in advance I wanted to address right away was, is the vaccine covered by Loyola's health plans? The answer to that is yes. Both our health plan provider Aetna and our prescription benefit provider CVS are covering vaccine administration at 100%, not subject to any copays, not subject to any deductibles. If you don't have our health insurance, most vaccine providers that are available, both retail or or any of the healthcare operations, they're charging a nominal administration fee. It's roughly about $25. We've also got a lot of questions in advance about, can staff, faculty take time off to get vaccinated? The answer to that is absolutely. From our vantage point here at the university, nothing is more important for you to do than to get vaccinated. It's going to protect you, it's going to protect your family, it's going to protect your friends, your colleagues, your campus community, the city, the nation, the world. So please, whenever you're able, go out and get the vaccine. A lot of worries. We have worries about how do we get the vaccine, and then also worries about, are you going to make me get the vaccine? The answer to that question is maybe someday. No one today, not even in healthcare providers, while it's an emergency use authorization, is requiring the vaccine. No one today would even have enough vaccine to require it. Many universities, Loyola included, are studying this. We have a healthcare advisory working group. Some of those key folks have been on the panel today, and we're looking at this for the future. Today, I should remind the campus community, we do require influenza flu vaccinations at the health sciences campus. We also require a series of vaccinations or proof of a series of vaccinations for our students under Illinois law. So we continue to look at that, and we'll look at it someday in terms of potentially requiring it of all or some of the campus community. I'm going to stop there and turn it back over to Elaine.
Yeah, thank you, Tom and Phil. You know, as I listen to you, it just really underscores how fragmented our U.S. health system is, and how complex distribution is, as we have federal, state, and local. And we as employers are embedded in that complexity and trying to work our way through that. So we had a few pre-questions. I've been monitoring the chat. We'll try to weave in as much as we can. So my first question is for Phil, and it has to do with, we get several questions around qualifications. So one that has popped up a lot is, where do graduate students who teach courses fit within that sort of classification in terms of higher ed? Do they qualify?
Sure. Thanks, Elaine. I'll be happy to tackle this one. Again, eligibility in the phases that are currently broken out, phases 1A, 1B, 1C, are established by function, by work, as well as by age and comorbidity. As I mentioned earlier, we've been able to get several groups of workers, including student workers, eligible in phase 1A and 1B. Anyone who's teaching in a classroom, including graduate students, will absolutely be eligible in phase 1C. Anyone working in higher education will be eligible. So it's not so much your status as a graduate student. It will depend upon, are you teaching? Are you doing something working with students that would require you to be a priority in phase 1C?
So if they're an instructor or something, that would be the proof that we do. Okay. There were a lot of detailed questions. People have specific situations. What if they don't see their group on one of the lists? How do they find out more information to have that more nuanced understanding?
All of these lists are currently being updated. I was on the state of Illinois' website today, as well as the cities, and they both have disclaimers that they are still in the process of identifying who is and who is not an essential worker. Also, as I mentioned, we're expecting this in 1C that there will be subgroups or tiers within phase 1C, but those have not been identified yet. But this is why we encourage everyone to constantly be revisiting the site. And ultimately, we hope to provide, or will be providing, one-stop shopping through Loyola's own vaccine webpage.
Yeah, very important. It's evolving, emerging, and during a pandemic, we're building the plane as we're flying it, so to speak.
That's the phrase.
Yeah. So Tom, all right, once I find out I'm eligible, when, many wonder, will it be available for Loyolans at Loyola? Any comments on that?
Sure. The answer to that question is not in the foreseeable future, but we are making plans to do that as soon as the vaccine is widely available. I do want to say a couple of things. We have been able to partner with Loyola Medical Center and be able to identify and designate and vaccinate up to about 2,500 students, faculty, and staff who are at that campus, who are therefore being treated as healthcare, most of them non-patient facing, just as they did. As Phil indicated as well, we were able to work with the vaccination program out there, and although the vaccine capacity wasn't there, we were able to designate about another 500 students, faculty, and staff who qualified under some of those, I would say odd, but varied and specific frontline essential categories. And so those are the things we've been able to do that. It isn't going to be feasible for LUHS or Loyola Medical Center to become the vaccine provider for the entire university. We're grateful for everything that they have done for us. We know that they need to and are focusing on the tier 1A healthcare providers. They're focusing on the tier 1B and on their patients who are 1 in 1B, who are 65, who have comorbidities, who are also qualified under any of those frontline essential workers. What we are doing is consistently communicating, everybody get the vaccine whenever you can, as soon as you're eligible. We are contracting with other vaccine providers that are providing that provide vaccines to employers. Many of you who go to our employee health and wellness fairs know those firms, and we are looking for them. They, like most people, are waiting for the supply to be available. We are also looking to become a vaccine provider ourselves so that we can do it in a greater scale and for the communities in which we serve.
Yeah, that's fantastic news. And I want to just personally thank you for your advocacy and how you've, you and Phil have been advocating on behalf of us as constituents to get to be qualified as early phases, as well as to help facilitate access as well. So a question I have now back for Phil, is there anything more other than information that, vaccine appointments are hard to make? Is there anything else we can tell people to help streamline that process for faculty and staff and students? Other than be
I wish I could say yes. As I mentioned in my remarks, and as you just echoed, the difficulty right now is the current very limited supply, and the distribution is at the sole discretion of the prevailing Department of Public Health. Employers, vaccine providers have no way to speed that up. We do hope, though, that again, with the vaccine webpage, that will be of great assistance by giving everybody at Loyola a single platform to go to, whether you live in Chicago, whether you live in Cook County, wherever you live, to get vaccinated as quickly as possible.
Yeah, because those websites are staying current with whatever is the latest information and availability as well. Okay.
Yes, but check frequently because it changes.
Yeah, I can speak personally. My sister is a teacher, and suddenly CVS became open, and you just have to know to be paying attention when these new sites are opening. Okay, so let's assume we get vaccinated and we're thinking future forward. I think you addressed the question around whether or not staff will be required before returning to the campus. So I'll leave with the other question for you, Tom, what are the implications for fall return and our plans? And, many of us know that incoming freshmen are making decisions and other universities are making announcements. Is there anything you can share with us around our fall return plans.
Sure. Our plans have always been about more gradual and phased reopening from fall to spring, from spring to summer, from summer to fall. We are very, very optimistic that we will be able to do more in-person instruction in the fall. The vaccine is a huge part of that. We also are not going to do anything that's not legally allowed or medically advisable. The struggle that we have, the constriction points are the number of faculty available to teach and the amount of space that we will need to teach. And we don't know what that's going to be yet, to be honest. I don't think most of the other campuses in the country know what that's going to be yet. So our signaling is, and it's true, is we are going to be able to do much more than we're doing now. But we don't know what's going to be legally allowed and medically advisable as we get closer. And so, like everything with COVID, we're going to get a lot smarter later. But we're struggling to figure out how late it is that we can be smart.
We all want to go back to normal, as Abigail was showing us, and we all want that to be sooner than later. And right now we're in a race to herd immunity. So hopefully today is, and the continued efforts of the university to help our collective community in achieving that, so that we have more flexibility to be opening and getting to normal again. So I'll stop there with the Q&A part, and I want to thank you again, Tom and Phil. We really do appreciate your leadership and advocacy at both the government level as well as partner level with the health system. And so now we're going to close it out with what does this mean about considerations now back on campus? And we're bringing back on now Kena Henning, who's the Associate Vice President for Facilities, as well as the leader of our MPC operations and campus continuity, and Joan Holden, who directs our Wellness Center and is also our university leader and safety officer around what will change once we have vaccination and what will stay the same right now. So I'll let you go, Kena.
Actually, I'm going to go first, Yulene.
Sorry about that, Joan.
No worries. Hello, everyone. I'm happy to be with you again tonight to talk to you a little bit about how things will change for us in the presence of a vaccinated population. Masks and social distancing will remain even as people are vaccinated. I know there are questions about why we are still asking people to wear masks even after they have been vaccinated. Unfortunately, face masks and social distancing will continue into the foreseeable future. As we've mentioned, getting vaccinated does not mean that we can go back to life as we knew it before. Until we have that herd immunity that Dr. Silva talked about, we should consider the vaccine to be another layer of protection against COVID-19. In addition, individuals do not reach the maximum effectiveness rate against COVID until a couple weeks after the second dose of the vaccine. And although effectiveness of the vaccine is high, they do not provide 100% protection, as mentioned earlier. It may be possible also that people who are vaccinated could be asymptomatic spreaders of COVID-19. And although the vaccines prevent severe illness, more research is needed to determine if the vaccine also prevents transmission. If vaccinated people do not wear masks until more people receive their vaccine, that may cause the virus to keep circulating. Getting vaccinated means you are much less likely to get sick and develop symptoms yourself, so it's critical that we protect others while we wait their turn for the vaccine. In addition, it's important that we protect populations who can't get vaccinated for medical reasons. As you know, masks are our greatest defense in slowing the spread of virus, and universal mask wearing is endorsed by the CDC and Loyola University. It should be mentioned that masks are not a substitute for social distancing, and although masks should continue to be worn, we must still maintain our policy of maintaining at least 6 feet apart. Masks also should completely cover the nose and mouth and fit snugly against the side of your face. Wearing a mask improperly is like not wearing a mask at all. I want to talk just 1 second about surveillance testing after vaccination. Many people have asked about why we test people for COVID after receiving the vaccine. As we mentioned in an earlier email to our campus community, although we initially exempted this population, the recent reporting of COVID-19 variants, which may be more prevalent than currently known, is a factor in our revised policy. The data is still emerging regarding how the variants may influence vaccine effectiveness, as Dr. Clark mentioned. Therefore, we still ask that all students, faculty, and staff who have received a completed vaccine series continue to participate in our surveillance testing program. Kana?
Thanks, Joan, and good evening, everyone. So a little bit more about our surveillance testing program and the success that we've seen from that program. So since we began our surveillance testing at the start of the spring semester, we've administered over 40,000 surveillance and diagnostic COVID tests. Right now, we're administering about 6,000 tests per week. And we're very happy about the fact that our positivity rate has continued to hover at around 0.5%, which is lower than the community positivity rate, which is currently at about 2.9% over that same period. So we've seen that with good compliance of our surveillance testing program, masking, and social distancing, we can keep the Loyola community safe and healthy. We do take compliance very seriously, and we continue to monitor for isolated instances of noncompliance so that we can address those individuals, remind them of the importance of testing, and to help keep the rest of the community safe by ensuring that everyone is compliant. We also want to remind you that it's important to just keep track of your symptoms daily. You can use the Loyola Health app to track your symptoms and be mindful of your health before coming into contact with others. But having the surveillance testing program in place has really proven to be a tremendous resource to us. And we will be prepared to test an even larger volume of students, faculty, and staff in the fall semester. Our program is scalable, and we have the resources available to be able to scale up and accommodate even more testing as needed. We know that we have the space, the staffing, and additional resources, and Shield Illinois is prepared to support us in that effort. So we encourage everyone to remain vigilant in their regular testing regimen. And those who have been testing regularly can tell you that it is quick, it is easy, and it becomes part of your normal routine in no time. So I think that we can expect to see that all of these mitigation measures will still be a part of our life, but will also continue to keep us safe and allow for us to return to a greater sense of normal.
Right. Thank you. Thank you for that. It sounds like Loyola is using evidence-based strategies that work, that we have a surveillance system that is working, and we're seeing good results around our community relative to the community around us. And that's very comforting to know, and that the vaccine is just another tool in the toolbox that will just continue to help us mitigate and get back to normal. So that's wonderful to hear. And thank you all, you both, for your tremendous work in standing up a surveillance system on 3 campuses is no small public health feat. And we're very fortunate to have your talents in helping get that going. So my question that it came in, and this one is for you, Kana, is there a target percentage of the Loyola community that has to be vaccinated before we can lift our local health and safety restrictions?
Yeah, great question. We expect to receive additional guidance in the coming months from CDPH and IDPH on this. By the time the fall semester begins in August, we anticipate that every faculty and staff member will have had the opportunity to be vaccinated. And of course, we encourage everyone to do so. So we will be monitoring, obviously, local community herd immunity rates. We also know that our operating decisions will be based on other metrics, such as our rate of new cases and positivity. So it will likely be a combination of factors that would guide our decision about how we would be able to lift certain restrictions and what those new guidelines would look like.
Yeah. Yeah, we live in a porous system, don't we? It's our campus, but our campus is in a community that's in a tri-state region, and we really have to be looking at what's going on, knowing the commuters that are coming and going as well.
That's right.
So I want to thank you guys for making sure that we have the basic block and tackling so that we can continue to fight this. So I've noted that we've now answered over 100 questions. I know there's a few more in the chat. This is the end of our prepared remarks. And I want to thank all of the panelists for taking time today to be able to share this information with our Loyola community. And the group here will be staying on to answer questions as much as we can, but I'm told to remind you that in the chat is the link, but I'll just say, if you want to stay up to date, these links that we had in here are luc.edu/return to campus. And we hope that you've learned something today, got some of your questions answered, and know where you can turn to continue to stay informed. I want to give a big thank you to my colleagues here on the panel, but also to those behind the scenes in digital media services, university marketing and communications, and of course, all of those Q&A responders that have been working with us. Together, we can do it. It's our collective action and how we support one another and the decisions each of us are making to do what's best for ourselves and our community. And we're all in this together as one Loyola. And I thank you for the opportunity to be able to moderate discussion today, and in gratitude with University Senate to make sure that we're all partnering together to answer your questions. So thank you very much.